Good afternoon, everyone. Welcome to today's Endocrine Grand Rounds. We are very happy to have one of our own. We are very happy to have one of our own endocrine surgeons here, Amy Quillo, present today on parathyroids, tiny but mighty, surgical perspective. Dr. Quillo is from Louisville. She did her medical school and residency at the University of Louisville, and then went to the Mayo Clinic to train in endocrine surgery. And fortunately for us, she came back to Louisville and has been at the University of Louisville for almost 15 or more years. And now she's still with us from our point of view.
Yeah.
She's just across the road she operates at Norton, endocrine surgery. Her interests have been in thyroid and parathyroid and also adrenal, like any endocrine surgeon. We have known her for a long time, and she has worked on these areas of thyroid and parathyroid surgery and published in this field. As all of you are aware, there have been progress made in diagnosis and treatment of parathyroid disorders. And so I will have Dr. Quillo, discuss the up-to-date things on management of parathyroid surgically.
Thank you. Appreciate it. Thanks for having me. I appreciate being here for sure. It's always interesting because we overlap a little bit with I do a little bit of the medical workup, but I think just bringing that surgical perspective and kind of getting a little more information about that can be helpful too for you guys who don't make it into the OR all the time. So I think thankfully on your part most of the time. But we'll talk a little bit about all aspects of the parathyroids. Really want to concentrate mainly on primary hyperparathyroidism and then surgery for primary hyperparathyroidism. But we'll touch on some of these other issues, and obviously happy to take questions along the way or at the end, either way. Basically, as you know, there are typically 4 parathyroids. We call them the superior and inferior glands, but honestly, that relationship is different in everybody. I mean, everybody's anatomy is so different. And really that superior inferior relationship holds most often, but really I see the relationship between the parathyroids and the recurrent laryngeal nerve or the vocal cord nerve is kind of the more consistent relationship. So we'll talk a little bit about that. The parathyroids, as you can see, if this is a posterior view of the thyroid, they are kind of lying on the back of the thyroid. This is a very cartoonish, drawing. Obviously, they don't look like that normally. They're a lot harder to find most of the time, and there's a lot of surrounding tissue around everything, so it obscures things a little bit. But in general, that is typically where they're located. Your patients will say they read it was like a grain of rice. I think that's probably fairly accurate. I usually say the size of my pinky fingernail is what a normal one looks like, and then obviously abnormal ones can be bigger than that. Superior parathyroids and inferior are derived from different embryologic pouches. So that's why they kind of move along those pathways embryologically. And so I always tell the patients, it kind of just depends on when you were formed in the womb, where did they get dragged along that pathway and where do they end up? So that's different in everybody. They don't move around. It's just wherever yours are is kind of where they are. So the superior ones are a little bit more consistently located right by the entrance of the inferior thyroid artery. So right on the back there, right by the nerve to the vocal cord. Inferior is a little more variable, as we'll see. This is just a little bit of a schematic to kind of show you percentage-wise where we normally find them. So on this side is the inferior parathyroids. You can see the majority here, 56%, are right around that lower pole of the thyroid, but it's a lot more variable. A lot of them are down in the thyrothymic ligament or in the thymus. They can be, even the inferior ones can be above the superior ones, but they're almost always anterior to the recurrent laryngeal nerve. So that's the most consistent relationship that we see, is that anterior, more superficial. So even if I see them up high, most of the time the inferior parathyroids are on the front of the thyroid. They're a little more likely to be inside the thyroid. So as a surgeon, when I'm thinking about that, if I can't find them where they're supposed to be, then I start to think about all these other locations that they could be and start to look in those areas. And our greatest success is me just knowing the patterns and doing a high volume and always knowing where to look next, basically, to try to find those. The superior parathyroids, like I said, 77% you can see are right there. That yellow structure is the recurrent laryngeal nerve going up. They're usually a little bit behind that, kind of posterior to that, tucked right behind. And that's a pretty consistent relationship there. I'd say in my experience, it's probably even higher than 77%. I always am glad if I'm looking for superior one because I can almost always find it where it's supposed to be. Those two, though, can be down in the chest. They're usually very, very posteriorly located behind the esophagus down in the chest. They can be up very, very high. I've found them. We had one the other day that was, probably 3 centimeters above the thyroid gland up by the ear. So I think the biggest thing with parathyroid surgery is that all bets are off. You have no idea where they are. And so it's just a matter of volume and pattern recognition to try to figure that out and find them. Because the best thing you can do for the patient is to find it at that first surgery. The last thing we want is to have to go back and look for them through scar tissue and things like that later. So and then again, just to stress that they can be all over the place. So we really, again, volume and just doing more and more of them to kind of figure that out. Kind of going back to, or going along to the way that calcium homeostasis works. We won't spend a lot of time on this because I know you guys get this in other areas, but the way I kind of talk to the patients about it to make them understand is to kind of compare it to a thermostat for the calcium. When things are working normally, if the calcium in the blood gets low, the parathyroids are supposed to come on and start making parathyroid, and that's normal function and that's appropriate elevation of the PTH, and that's telling your body you need more calcium. That works in various ways on the bone, kidneys, in the gut to mobilize calcium into the bloodstream. If things are working right, as that calcium rises, then the parathyroids kind of settle down through feedback mechanisms to kind of go back to normal. So we'll talk more about the lab workup in a bit, but the biggest thing that I tell the patients and mainly for the primary care doctors is when we're looking at a diagnosis, we want to see the labs in relationship to each other. An isolated calcium or an isolated PTH really doesn't mean a whole lot by itself because the PTH could be high because the calcium is really low or the vitamin D is low or whatever it is. So you really want, when you're evaluating to get that full set of labs, and we'll talk a little bit more about that. But, here again, it works on the bones to mobilize calcium, and it also inhibits osteoblasts, so it keeps it from being put back into the bones. So that's why we can treat parathyroid patients with calcium, but it's not as effective because it's never going to kind of get to where it needs to go in that situation. So we are a little careful about giving parathyroid patients calcium. There can be other causes of hypercalcemia. By and large, the most common cause is hyperparathyroidism, especially in an outpatient setting. That profile changes a little bit when you talk about inpatients because they're more likely to get those metastatic cancers and things like that. But in general, if you see a patient coming in with high calcium just on screening labs, they got a BNP for whatever reason, and they have high calcium, obviously it could be a fluke, but the most common cause of that would be parathyroid disease. So definitely needs to be worked up first. You can see obviously the other causes, and really we don't look to the other causes until we've gotten that initial profile. If you see a high calcium and they have a non-suppressed or elevated PTH, that's parathyroid disease. You don't need to look anywhere else. You know where it's coming from. If you see a high calcium and the PTH is 10 or 0 even, then you know, okay, parathyroids are acting normally. They're suppressed like they should be. Let's look at these other causes and see what we can figure out as far as a source. We all know sort of the clinical presentation. It's tested on every test I think that we ever take in our lives with the stones, bones, groans, and psychic overtones. And that is very true of the patients coming in to see me. About half of my practice is parathyroid disease, and it's always a constellation of these symptoms. It's very interesting to me that the symptoms are very different person to person. They have the exact same set of labs, but they come in with very different symptoms and how it's affecting them. So I think just teasing out some of these symptoms is difficult sometimes, but just making sure you're thorough and asking about memory stuff and kind of the neuropsych symptoms are a little bit harder to tease out sometimes. But a lot of times patients will come to you and tell you they have all of these things, especially with the internet easily available. They've looked it all up for sure. I think the biggest thing that I see from my parathyroid patients is that I just don't feel like myself. And their family will say that too. Like, they're not like this. This is not them. They don't usually act like this. They have no energy. They're foggy. They're forgetting things, all of that stuff. So that's a very common saying that I hear. The subtypes of hyperparathyroidism, we'll go through each of them individually, but I think this is a nice chart to kind of give a synopsis of what you're looking for as far as the ratios. And this again highlights that you're looking for things in relationship to each other. So if the calcium is high, it's okay for the PTH to be low. That would be normal. But if the calcium is high at the same time as the PTH is high, then you know it's coming from the parathyroids. I think too, a lot of people don't recognize, especially primary care more, that when a calcium is high and the PTH is high normal or kind of mid-normal, that's also inappropriately elevated for how high the calcium is. So you have to be a little bit careful about that. You see a normal PTH, but if it's in the setting of a calcium of 11.5, then that's inappropriately elevated for that level of calcium. And so those patients do have primary hyperparathyroidism. It's called normohormonal primary hyperparathyroidism, but we don't really distinguish. We kind of throw those in with primary. You can see here with different subtypes, like secondary hyperparathyroidism, their calcium is usually lower normal because it's driven by a different mechanism. They always have low calcium and they always have high phosphorus. And so that's always stimulating those parathyroids all the time. And so they tend to become autonomous. And we'll talk a little bit about when we need to do surgery in those patients. And then other types of secondary hyperparathyroidism, again, low calcium or low vitamin D can also stimulate the parathyroid. So we have to be careful when we're talking about surgery. We don't want to operate on parathyroids if that's not the source of it, if we can figure out there's something else going on. So we'll talk a little bit about normocalcemic hyperparathyroidism and just making sure of that diagnosis. Primary hyperparathyroidism, again, the most common thing that I see usually in the 5th or 6th decades, but honestly, I see it all over the spectrum. I've seen it anywhere from, we had a 14-year-old that we operated on, a few weeks ago, all the way up to, I think the oldest patient that I've operated on was 94, and she was healthier than a lot of my 50-year-olds. So she was like, this is affecting me. I want it out. I know the risks, and everything. So she did fantastic. She felt great afterwards, did great with anesthesia. So, I mean, there's no age where I'm like, okay, you don't need this. It's kind of very dependent on the patient's presentation and their symptoms and their lab results and everything. Obviously more common in females, although I have gotten a lot of male patients too. I mean, it definitely happens, but certainly more common in females. Sporadic and familial are obviously the two main types. We'll touch a little bit on the familial, but we'll talk about more of the surgery in general rather than the subtypes in detail. But basically MEN1, we'll talk more about that. MEN2A, MEN2B doesn't typically include primary hyperparathyroidism. And then parathyroid jaw tumor syndrome, I've seen it a couple times over the last 15 years, but it's extremely rare. And it's a little bit more associated with parathyroid carcinoma, which is, those are the patients that I've seen with that as well. These numbers typically do hold true as far as what we see surgically. It is almost always a parathyroid adenoma, 85% of the time. Parathyroid hyperplasia, I feel like, used to be more like 10%. It is creeping up a little bit, I think, because we're recognizing parathyroid disease a little bit early and finding milder disease where it may not have presented as early, or we may not have recognized it as early in the past. And I feel like a lot of those patients with lower calcium, lower PTH tend to have more hyperplasia for whatever reason. The patients who have really high calcium and really high PTH, it's not 100%, but tend to be the ones that have adenomas, interestingly. You can't really tell under the microscope whether it's an adenoma unless you see normal parathyroid tissue with a tumor. Otherwise, the parathyroid cells are hypercellular, whether it's related to an adenoma or hyperplasia. So it's more related to the clinical picture. What do the other glands look like? What do the PTH levels do? Which we'll talk a little bit about that too. MEN1, as you know, again, tested on every test I feel like ever is these two syndromes. They love to ask questions about these. So just knowing the components of each of these can be helpful. I think the big thing with MEN2A, most of these patients present with medullary thyroid cancer. And so when a patient comes to see me with medullary, or you or anyone with medullary, the biggest thing is to rule out these other two diseases. We never want to go to surgery for the thyroid cancer without ruling out these other two. We don't want to get the patient in the operating room and asleep and they go into hypertensive crisis because they have a PHIO. So plasma metanephrines and normetanephrines are great screening for pheochromocytoma. If they are negative, then the likelihood of PHIO is almost zero. So if they're positive, there's a lot of false positive results. So typically we would get urine in that situation, but to start with plasma metanephrines and normetanephrines is a great screening tool. It's great for the patients too, because they don't have to do the most of the time don't have to do the urine collection, which they hate to do. So that makes it a little bit easier. And then anytime we have medullary, we always check for primary hyperparia. You want to know that going in. There's also a lot of data about certain genotypes with MEN2A that predict certain phenotypes. So if you don't have to memorize those, but if you have a patient that you know genetically they have MEN2A and you can figure out what their genotype is and what their family kind of pattern is, that is very predictive of if they're going to have these other things. So you can be a little more aware and screen earlier and things like that if you know that they have a specific subtype, which is nice. If they do have both medullary and primary hyperparia, we can take care of everything at once. And that's the main reason that we want to know that ahead of time. When you're working up a patient with hyperparathyroidism, obviously, all of these things with history matter. Symptoms is a big one just because that's going to help you decide whether or not they're a surgical candidate if they have symptoms. So just being very thorough about that. Radiation therapy or radiation exposure in a job or anything like that can be a risk factor for this. So it doesn't really change what we do, but it's kind of interesting to know. You can kind of give the patient an idea of why they might have parathyroid disease. And then family history is super important because that may change your surgical approach. If you really find out like, oh, my cousin had it, and then my sister and my 3 brothers all have parathyroid disease, they all needed, they all had multi-gland disease, I'm going to be more likely to look at all 4 glands during surgery rather than try to attempt a minimally invasive surgery. And we'll talk a little bit more about that too. Physical exam, not super helpful with parathyroid. The chances of feeling a parathyroid are almost 0. I mean, I guess theoretically, if they had a bad parathyroid cancer, you might be able to feel that, but even that would be a little bit unlikely. You're not going to diagnose parathyroid cancer based on physical exam. Usually you're going to see that in their labs way before you can feel it, but obviously helpful to do a good physical exam. And then rare would be a hypercalcemic crisis. We see those. I've maybe in 15 years had 2 or 3 patients over the years that needed an emergent parathyroidectomy. Most of the time you can stabilize them, normalize the calcium medically, and have them get outpatient workup and scans and everything. So it's pretty rare to need emergent parathyroidectomy, but it has happened over the years every now and then. The biggest thing with parathyroid disease is diagnosis. Diagnosis is all biochemical. The imaging doesn't have anything to do with diagnosis, and I think that's one of the big things to take away from this is that we don't care what the scan shows. We don't even get the scan until we know they have the disease and are a candidate for surgery, because if we got the scan on all of you, they're going to see something on the scan. So then the patients get fixated on, well, I've got this parathyroid tumor and all of this stuff when they don't actually have the diagnosis. And so before you get anything scan-wise, I would definitely make sure that you confirm the diagnosis. And so like we talked about before, that's just getting this set of labs to kind of see how those labs interact with each other. What's the calcium related to the parathyroid hormone, vitamin D. 24-hour urine, I feel like has come back in for a while. Nobody was checking that, but I feel like it's come back in over the past probably 5 years or so that most patients get that as well, mainly to rule out FHH, but also to kind of see the risk of renal complications and decide about surgery if they're asymptomatic. So that's something that we normally get. And then most patients will have already had a DEXA scan, but you can get one too as a baseline if you need to. The big thing here, again, as with the graph, high calcium, non-suppressed or high PTH. Serum phos is typically kind of low normal. It can be low, but usually we see it kind of in the normal range, just a little bit on the low side. And then FHH, we'll talk a little bit. Obviously, it's non-surgical, but that is, nothing to do with the parathyroids themselves. So taking out parathyroids won't help this. And so that's why it's super important to recognize that ahead of time. And those are patients where you can look back and see that their calcium was always kind of high normal or just above the upper limit of normal. They never have a normal calcium, and I have had a couple patients that we've picked up on this. They usually have mildly elevated PTH levels too, or when it's been checked. And then you get a 24-hour urine and their 24-hour urine is very low. And so typically, if I see that constellation, then I will go ahead and send them to genetics. They'll do a workup and get that diagnosed. And then obviously those patients don't go to surgery because it won't be helpful. Family history too is important. If they say, oh, everybody in my family has high calcium, then you start to think of that in the back of your head, like, oh, maybe this is FHH, although it is very rare, I will say. Vitamin D deficiency is a little bit, everybody has an opinion about it. Definitely check it, in the setting of primary hyperparathyroidism. Some people are a little bit more aggressive about repleting the vitamin D before surgery. There are some patients who are very sensitive to it. So I've had patients that we were aggressive about, or somebody was aggressive about it, and their calcium bumped up really high because of it. It's pretty rare to see that. Most of the time, the calcium stays pretty stable. So most patients will get vitamin D supplementation before surgery. You just have to be a little cognizant of checking labs after you start it and things like that to make sure you're not dealing with one of those rare patients that bumps up. Next would be talking about the decision for surgery. So not everybody with primary hyperparathyroidism needs surgery. It's a vast majority of them, but you have to be a little careful. And patients, just obviously there are risks to a surgical procedure. It's a pretty straightforward one, pretty low risk, but obviously we want to pick the right candidates. So definitely first, get the diagnosis. Biochemically, that's the most important part. If a patient has any symptoms at all and they have the diagnosis, they're a candidate for surgery. And so obviously in patients who just had a heart attack, last week, or a stroke or something like that, you'd want to obviously take a step back. But in patients who are a good surgical candidate from a medical standpoint, comorbidity standpoint, if they have the diagnosis and they have symptoms, typically would offer surgery regardless of what their imaging shows, or even before imaging, you make that decision. Once you've decided they need surgery, that's when you get the imaging. And imaging is really very dependent on the surgeon. So we'll talk a little bit about surgeon preference for that. In patients who have the diagnosis and don't have symptoms, that's when you get into the subset of criteria for asymptomatic patients. And so I do have a lot of patients. I do think a lot of my asymptomatic patients, if you truly tease out, they probably are having some subtle symptoms. I see that a lot in patients who are post-surgery, where they're like, they are adamant that they're not having any symptoms at all. And then they see me, 3 weeks after surgery, and they're like, you know what, I feel so much better. I think I was really having some symptoms. I feel clearer, sharper, whatever it is. So, asymptomatic is a little bit relative, but in patients who are truly asymptomatic, they still meet criteria for surgery in these subgroups. So definitely high calcium, that's been greater than 1 above normal, has been predicted to cause complications down the road. So those patients are definitely candidates. They don't have to have all of these, but just one of these criteria to meet criteria for surgery. So patients with osteoporosis, obviously you're starting to see some end organ damage from the primary hyperparathyroidism. So those would be candidates. Yep.
Would stones be a criteria?
So stones is technically considered symptomatic. So that's what it would fit into the symptomatic part of things. And so those patients would be taken care of in that. If you have an x-ray that shows asymptomatic stones, then yes, those patients would. But generally, patients with stones are coming up with symptoms, and so they'd meet criteria based on that. But good question. And then young people, obviously, when we talk about young people that have the definitive diagnosis, the worry there is that they have such a long time to develop problems from the primary hyperparathyroidism. So under 50, if they're healthy, the likelihood of them eventually down the road having a problem, this would be a lot higher. And so typically we recommend it in patients around 50 or less. It's also a lot of surveillance. So in patients who have that, you're going to be checking it every so often to make sure their calcium doesn't get higher, that kind of thing. So we think that cost adds up, in younger patients as well. And then if they already have a low GFR or declining GFR over their surveillance period, those are reasons to talk about surgery. And then plus or minus 24-hour urine. Again, this one comes in and out of vogue a little bit, but I would say right now most patients, if they have a high 24-hour urine for calcium, then that would be a criteria for surgery just because of the risk of renal complications over time. Again, like it says there, biggest thing is just trying to choose the patients who are going to go on to have problems with this to take care of it before that happens, if that makes sense. Like we talked a little bit about, there are people that think everybody needs surgery. And I think as a surgeon, I probably lean a little bit more towards that way. I'm biased, of course, but I do think, like I said, it's hard to tease out the symptoms sometimes. We do see improvement in bone mineral density over time. So certainly in patients who have osteopenia, where you're starting to see some of that, especially if it's at a young age, we typically think they might benefit from surgery as well. The expense of follow-up, patients don't follow up, or they don't come back and then end up with complications. So I think there are truly patients who don't need surgery, but I think a vast majority of patients with the diagnosis typically meet criteria in some way. And then the people who kind of argue against surgery look to studies that say, hey, in asymptomatic patients, there are a large population that don't go on to have problems with this and don't meet really any of those criteria. And there certainly are patients that, that meet that. Like I mentioned, the localization is very surgeon dependent. It's very different city to city. So I have friends that live in other major cities where they know in their city that there's a certain scan that works best for them. It's all about, the location, what they've done before, that pattern recognition, what's worked for them in the past. Here, the Sesame Spec CT that's done at UofL is by far the best scan that we have in town. It now takes almost 2 months, I think, to get in to get one of those just because everybody sends their patients there, but it is definitely gets the best results and the most reliable results. So I would definitely recommend that. That basically is taking two components. It's a sesame scan where we inject sesame. It gets taken up by the thyroid and the parathyroids, the mitochondria, and then it will wash out of the thyroid and kind of linger in bad parathyroids. It doesn't show normal ones, but will linger in bad ones. And then the CT component is sort of fused with that. So we can see if there's an area that lights up on the sesame part, and I'll show you a picture of one of these. Where does that correlate on the CT scan, and gives me kind of triangulation to be able to get there as reliably as possible. 4D CT scan is also helpful, but I've got a lot more false positive results with that. So I'll show you a picture of that too. It's a little less reliable because it's not dependent on function. It's purely anatomical and the washout of the contrast and the density of the tissue. So there can be a lot more kind of tricky false positives with that. And then ultrasound is great. I use ultrasound in the OR to kind of look and confirm and kind of guide and plan for where my incision is going to be and things like that. So ultrasound is great. It also is very good at showing the thyroid, obviously, so we can see if there's any concomitant thyroid pathology that we need to take care of. These other scans, as you know, CT is not the best way to look at the thyroid, but will typically show you if there's something obvious there. So all three of those are great at thyroid as well, but ultrasound is probably the best, of course. This is kind of an old school plain sesame scan. So this is actually a beautiful one. We never get results that are this clear, but you can kind of see here, there's the heart and then the salivary glands take it up a little bit. And then this one, it's washed out of the thyroid and is lingering in the parathyroid adenoma. This is fantastic, and I probably would be okay with using this. We'd have to get a thyroid ultrasound because it doesn't show the thyroid, but I'd be okay with using this as a targeted scan, but it doesn't give me any context at all. I don't know where the thyroid is in relationship to this. I don't know where it is in relationship to the nerve or the vessels or the trachea or anything like that. So we really have gone away from using just a plain sesame scan. Almost nobody uses that for localization now, although it used to be the gold standard. Here's the Sesame Spec CT. So you can see that same light bulb there. It's obviously a different scan. That one was the left lower. This is the right upper. But you can see where it lights up on the sesame part, and then you can see exactly where it is anatomically. It's a nice sort of transsectional or axial look at where exactly that parathyroid is. You can see the jugular vein there, the carotid. Here's thyroid here. Here's the trachea. There's esophagus. So I can go in straight to that, a lot more easily and kind of get a better context of where everything is when I'm operating. This is the 4D CT scan. And so 4D is basically the contrast timing. And so basically that is saying when we give contrast, the thyroid and parathyroid are going to take up the contrast pretty equally and be very bright on the scan. It will wash out of the parathyroid and linger in the thyroid. So it's a little bit opposite of the sesame. And so you can see here, this is a left upper parathyroid that's tucked right in that tracheoesophageal groove that's bright on the initial contrasted, and then it kind of washes out here on the post-contrast scan. And so that gives me an idea of what's going on there. Thyroid nodules can do that sometimes. Lymph nodes can do that sometimes. And so I do think, like I said, the 4D CT is nice. It gives good anatomy, but it's not as great because it doesn't give that functional component to it. And then ultrasound, I'm sure you guys are probably the most familiar with, having done that a lot, but the thyroid gland here, you can see your jugular, the carotid, and then this parathyroid kind of has that classic appearance of parathyroid adenoma there. So that's great, especially intraoperatively, I can kind of see where it is and what level it is to be able to kind of guide dissection there. Preoperatively, as you're thinking about sending to surgery, these are kind of the things to start to think about. These are things that I do when I see the patient, but just kind of starting to think about what's their cardiac risk. Would it be helpful to go ahead and get them in to see their cardiologist if they have a big cardiac history to get kind of clearance or risk assessment prior to surgery? The more of this stuff that can get started and going, the quicker we can get them to surgery. And so that's kind of things to have in the back of your mind. I'm also obviously happy to do all of these things, but have they had surgery before? In my mind, I'm thinking, did they have voice changes? Do we need to get a vocal cord exam? What that changes our risk profile and that kind of thing. So these are the things that I'm thinking about. Do we need to get a thyroid biopsy based on their sestami B scan? Do they have a thyroid nodule? I had 2 patients in the last week and a half that both got diagnosed with papillary thyroid cancer. They came in with primary hyperparathyroidism to me. We got a sesame B scan. They had something weird show up in their thyroid. We got a thyroid ultrasound, FNA, and they both had papillary thyroid cancer. So thankfully, we recognized it ahead of time, and I was able to take the thyroid out at the same time as the parathyroids and took care of everything at once, which was awesome, but a little unusual to see it that often, but it definitely happens, which is why we get that ahead of time. And then mediastinal parathyroids, they're not super common, but I've definitely seen them over the years. Most of those I can get to through cervical incision, so it's all about looking at the actual images to see where those are. If they're in the anterior portion of the mediastinum, in the thymus, I can usually get those up pretty easily. We can take the thymus out. If they're deeper in front of the aorta or posteriorly located, that's when I get my thoracic surgery colleagues involved. And sometimes I'll be available. So if they do surgery and do PTH levels and the levels don't drop, I can go into the neck and look further. Sometimes I start and see if I can get to it. If I can't get to it, they'll go in and try to get to it through the, usually they can do it thoracoscopically. But those are just kind of being aware that they're there. That's why that sesame B spec CT is so helpful, because it gives us a kind of an exact location of those and helps me to plan what do I need to do around the time of surgery. And then family history can inform the decisions too, because if they have a really big history of parathyroid disease and everybody had multi-gland disease and needed 3.5 gland parathyroidectomies, I can plan for that ahead of time. I'm less likely to take one out and be waiting on parathyroid levels and kind of wasting time in the OR if I know that we're likely to have to take more than one out anyway. Kind of just being straight with the patients, I spend a lot of time before surgery talking about expectations, talking about the risks of surgery. I draw them pictures. I'm very available for that because I want them to kind of know what they're signing up for. I'm not the old school, like, well, we're just going to do this and, you're going to agree to it and you don't know anything that's going on. So I'm very much, I want to educate them. I talk about the parathyroids, draw them pictures and everything so that they know what they're getting into and know that not everything can be cured by taking out the parathyroid. So I think that's just managing expectations is a big part of it. And we'll talk about that more with reoperative surgery too. Minimally invasive parathyroidectomy is a term that you'll hear. So this is it's probably the most common approach to parathyroid surgery. And it's really not anything to do with the actual incision size. It's more about the lack of dissection. So when we do minimally invasive, it means I'm going in, taking one out, sending it off to the pathologist, getting a frozen section. They confirm that we've taken out a bad parathyroid. Then I can actually test parathyroid levels during surgery. And that tells me if that's the only one. If the levels drop, usually they'll drop within 5 or 10 minutes of taking out that first gland. That tells me, okay, the likelihood of cure from just taking that one out is extremely high. And so that allows me to stop at that point. I don't have to mess with the other ones. There's no risk of hypoparathyroidism because I haven't touched the other glands. They'll definitely wake up and start working. The risk of nerve injury is a lot less because I'm just on one side and that kind of thing. So it limits dissection, limits risk, limits scar. If they ever need something done in the future to the thyroid or the other parathyroids, we haven't created scar around them. So this is our best bet, for taking care of the patients as the most straightforward as possible. Interestingly, if you look at all 4 glands and still take out one, the chance of recurrence of parathyroid disease is the same as if you just take one and do the PTH levels. So there's no benefit in just looking at them. They're not abnormal right now, but they could still, go bad in the future, I guess. And that's the same whether you look at one or look at all 4 of them, as long as you do the PTH levels. Bilateral exploration is more reserved for patients who don't have a target on imaging. So if I don't know where I need to go first, then I kind of have to plan on looking at all 4 glands. We also plan this, obviously, if patients have a family history or have MEN1, and we know that they're all involved in the process, that it's more of a genetic thing. I know I'm going to be taking 3.5 glands out. We wouldn't mess around with, taking one and doing the levels and everything. If all 4 of them are involved, then typically I send little tiny biopsies off of each of them. Usually I can tell by looking at them at this point, but we send little biopsies off to the pathologist. They confirm that they're hypercellular. We choose the most well vascularized one, the one that's kind of the easiest to get to if we ever had to go back after it. the most normal looking one and put a little tiny clip on that to mark it and take out half of it and take the rest of the parathyroids out. Anytime I do a 3.5 gland parathyroidectomy, I always send the tissue that we've removed for cryopreservation, and it's frozen just in case that little half of one doesn't work. We can actually go back, unfreeze that, and transplant it into the arm, and it will work like a parathyroid down the road. So we have that as a backup if we need to. We almost never need to do that. A half of one, for whatever reason, is plenty for regulation over time. Some of the tricks that we use during surgery, this is one of my favorite tools. It's the endotracheal tube that has a little patch that sits between the vocal cords, and that allows me to actually test the vocal cord nerves during surgery. And so it doesn't help me find the nerves necessarily. That's more kind of pattern recognition, but it helps me to keep those safe and keep an eye on them, confirm that they're working afterwards. So I don't have any concern afterwards about watching the patient and that kind of thing. The big thing too is, especially if you're working on both sides, you want to make sure the first side is working before going to the other side. If you have a problem with the nerve on one side, then going to the other side and having an injury on that side as well, bilateral injury, almost always means a tracheostomy for the patient. The vocal cords collapse, they can't get any air, we have to do a tracheostomy. And so obviously patients going in for an outpatient surgery and coming out with a tracheostomy is not ideal. So usually I use the nerve monitor mainly for that, to prevent a bilateral nerve injury. Thankfully, nerve injury is extremely rare. I had my thyroid out years ago and had a nerve injury during my surgery, so I'm about the craziest person about the nerves you could find. I'll do everything I can to keep them safe, and we've gotten that risk down. It's well under 1%, probably close to 1 in 1,000. It is a fixable thing. It's just a big hassle to fix. So we try to just obviously avoid that in the future, and this is a helpful tool for that. And then PTH testing, we talked about a little bit, but the big things with that are just making sure that it meets your criteria. So when we take out that first one and we check levels at about 5, 10, 15 minutes, I draw the levels straight from the jugular vein intraoperatively. Some people put in an A-line or do a big IV, which is, I think we're right there. I usually just use the jugular vein, and it's been shown to be equivalent as far as trusting the results and reliability of results. But the big thing is to have a drop of at least 50% and then to within normal limits. So in patients who have a PTH starting out of 250, I'm not okay with it just dropping to 125. We want it to really, if that's truly the only one causing the problem, usually it's going to drop really low, but we want it to be usually at least less than 60 to kind of confirm that was the one causing the problem. The only other thing, and I think the other presentation that I had one more slide, there are some new techniques for autofluorescence of the parathyroids. I don't really use those. I don't find them helpful, but the parathyroids will autofluoresce, the just type of tissue. They emit this little fluorescence. And so there are tools that you can use to test those and measure the level of autofluorescence compared to the surrounding tissue to confirm that it's parathyroid. There's some things that you can inject and use lights to kind of pick up that autofluorescence. So there are a lot, or lamps, excuse me, there are a lot of people that use those as an adjunct. I think most of the time, if you're to a level where you can pick up autofluorescence, you're close enough to the parathyroid gland, I can see it with my naked eye, so I don't know why I'm, adding time and expense to the patient and stuff like that. So I typically don't use those, but those are some things that are available out there. Reoperative parathyroidectomy, unfortunately, is fairly common. A lot of times I'll see where either, they had surgery elsewhere and they couldn't find the gland, or I couldn't find the gland, or, they've had a thyroid surgery before, or a spine surgery. All of those are considered reoperative parathyroidectomy. And so the problem with reop surgery is that you can't just look around as easily. There's a lot of scar tissue. So imaging is actually key in these, and managing expectations of the patient. So I really tell them, the scan shows this. I don't know for sure that this is a parathyroid. I think it's convincing enough that I'm willing to go in after it, but the risk of injury to your nerve is higher. The likelihood of this being the only one causing the problem, it could be, but if they've had previous surgery, they could have multi-glands, and so we might be right back there again. So I think it's just managing expectations is the biggest thing, and having a target. Obviously, we'll talk a little bit more about surgical volume, but an experienced surgeon that's all they do all the time is super helpful for lowering the risk and increasing success. And this is exactly what I was talking about. So surgeon volume matters. The more you do, it makes sense that the volume, the practice that you're doing it over and over and over again all the time, the less complications you're going to have. There's a lot of talk about minimum levels. Most papers say at least 25. 35 is a number that's thrown around a lot, and then 50. Those are kind of the low, kind of what you should be doing at a very minimum. thyroid and parathyroid are combined together because you're in the same area. So I think if somebody's doing thyroid and parathyroid that equals that in a year, that's fine. We do close to 500 a year thyroid and parathyroid surgeries. That's all I do is thyroid and parathyroid, basically adrenal every now and then, but less commonly needed. So typically most 8% of what I do is thyroid and parathyroid. So certainly have complications. I am nowhere near perfect. My husband would agree with that, but the volume of surgeries that you do by nature is going to decrease those complications. So, we've gotten those complications down, thankfully, pretty low. Speaking of complications, so these are the kind of classic things that we think of, persistent or recurrent hyperparathyroidism. If you truly get a drop in the PTH levels, that's very rare to have persistent hyperparathyroidism. It happens. Maybe I'll get one every couple of years or something like that. So, 98, 99% of the time, if you truly get a good drop in the PTH that meets our criteria, you're going to get a cure from that. Recurrent hyperparathyroidism, usually about 5%, I would say, of patients that have a single gland removed will go on at some point in their life to have this again. And so I'll see patients that I had a lady last week who had a gland removed in 1993. She had normal calcium for however many years that is, and then just came back with high calcium again. So you just kind of start that workup over. You try to get the op notes. You try to get all the information you can to try to reoperate. Hypoparathyroidism obviously can be an issue if you've looked at all 4 parathyroids. So again, not a risk at all. If you've just taken out one, as those other ones wake up, you can have a little bit of transient hypocalcemia. Usually it's minimally symptomatic, or if anything, but certainly if you've looked at all 4, even if you've just taken out 1 or taken out 3.5, you definitely can have some hypocalcemia and hypoparathyroidism afterwards. And then obviously nerve injury. Most of the time, the nerve injury that we get is what's called a praxis. So it's a stretch injury where that will recover over time, but it can take about a year for that to come back. So in the meantime, we can treat the patient symptomatically while we're waiting for that to recover. And then obviously anesthesia complications. Hematoma and infection are possible, but so rare. I mean, 1 in 1,000 is probably way overestimating both of those. It's super uncommon to see either one of those anymore. And then permanent is that permanent hypoparathyroidism. So let's say we leave half of one and that never wakes up. If we have tissue frozen, we can try to reimplant that and get some function. Typically, it's treating with calcium and calcitriol and other medications, HCTZ, trying to get the calcium levels up in the blood with a minimum amount of pills a day. But it can be burdensome for the patient. So I'll do everything I can to make sure they have at least a half of a viable remnant if we can. Recurrent laryngeal nerve transection is extremely rare, thankfully. Unintentionally, there are some cases of thyroid cancer and things like that we have to sacrifice the nerve, but unintentional recurrent laryngeal nerve transection should be an almost never kind of situation. In 15 years, doing about 500 a year, I think I've had 2 nerve injuries like that where I knew intraoperatively that there was a problem and was able to recognize it, repair it. They get some tone back, and so that's if you see that during surgery, the best bet is to repair it right away so that you can get some tone back. So it happens, but that should be very, 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 very rare, thankfully. Non-surgical management, obviously trying to stay hydrated, minimize bone loss, stay active. These are for obviously patients that either don't quite meet criteria for surgery or can't have surgery for some reason. We can treat with some medications as well. Cinacalcet is one of the common ones that's used. It's just not super well tolerated. It can be successful treatment in some patients, but a lot of side effects. It's expensive. It's hard to get insurance to cover it, and it doesn't always work. So not a fantastic treatment, but an option for sure. Normal calciumic hyperparathyroidism is sort of the bane of my existence. I get a ton of these patients and there's no real consensus on what to do with them. We think most symptoms from hyperparathyroidism come from the high calcium. And so when they have normal calcium with high PTH, you don't know if trying to lower that PTH is helpful or not. I think the biggest thing is to rule out other reasons for the PTH to be high. So you want to get an ionized calcium, you want to get a normal or a total calcium, PTH, vitamin D, phosphorus level, look at their medication list, try to do everything you can to rule out other sources of elevated PTH. In the setting of high calcium with high PTH, it's almost always parathyroid disease. And normal calcium with high PTH, we have to take a huge step back, maximize vitamin D supplementation, make sure their calcium's not low. Are they on any osteoporosis medications that could be causing the PTH to go up? There are other medications that can cause that. So I think the biggest thing is to rule out those other sources and really confirm that they have normal calciamic hyperparathyroidism. And then typically, if they have osteoporosis, we do offer surgery as a treatment for that, but I'm very, very hesitant. If they have any risk factors for absorption, like patients who've had a gastric bypass in the past or anything like that, we're not going to do it, because we know that for whatever reason the PTH is that high. If we're trying to lower the PTH, sometimes it lowers the calcium significantly, and that the whole reason their PTH was high was to keep their calcium at that level. And so there's a lot of debate right now about, whether or not to do surgery on these patients. I do everything I can to get out of doing surgery on these. I love operating, but if we can avoid operating on these patients, I will, unless we absolutely feel like it's necessary, just because the risk of complications and low calcium is so high. Secondary, oh yeah. I mean, it can go very high. I mean, we see where, in renal patients, it gets in the thousands, 4,000 or 5,000. Now, in renal patients where we know it's coming from dialysis and that chronic low calcium, chronic high phos, and the dialysis taking out that. In a normal patient, I mean, the highest that I've seen somebody come in where they didn't have high calcium, probably in the 100s, 200s. And as it gets up in that level, I mean, normally you're talking about like 80s, where the normal 75 or something. And I'm like, we're not going to operate on this. But if it gets to be in the higher hundreds, then that would be the patient that I'd consider. Like, why is it that high? There's nothing else that we can find that's causing that. Maybe this is the patient that, meets criteria for surgery. I think the biggest thing is a lot of patients will come in without an ionized calcium, and we check ionized and it's low. And so just treating that low calcium will bring it down. So it's just ruling out every possible other source of it, I think, is the big thing. What else? Yeah, managing the patient expectations too is a big deal. Secondary hyperpara, usually dialysis patients are where I see this. You can have, obviously, low vitamin D can cause what's technically secondary hyperparathyroidism. Low calcium can cause that. So it's anything that's not coming from the parathyroids. It's an external problem that's stimulating the parathyroid. So most of those are non-surgical. The only ones that are surgical are the dialysis patients, where they've tried everything that they can to control. And we'll talk a little bit about this. These are other causes of secondary hyperpara. Pathophysiology of that. Management typically is treatment of whatever is causing it. So if I see they have low vitamin D, it can take about a year for that to adjust. So we treat them with aggressive vitamin D supplementation, recheck, every 12 weeks or something like that to see how things have changed. A lot of times, like I tell the patients, it's all about how the levels are reacting to each other. So if I see your vitamin D is 27 and your PTH is barely elevated, and we bring it up to 40 and the PTH comes down a little bit, then we bring it up a little bit more and it comes down, it's all related to the vitamin D. If they have that initial set of labs and we correct the vitamin D and the calcium bumps up, then okay, it's the parathyroids that are causing the problem. And so I think I always tell them the more data we have, the better, as far as trying to decide where this is coming from and what we can do to help. But it's basically trying to fix the problem, and surgery typically isn't indicated unless your next set of labs shows a different story. CKD and dialysis patients, the biggest thing is to try to maximize their control of the calcium and phosphorus to try to avoid further stimulation of the parathyroids. And so that's all done by their nephrologist typically to try to maximize treatment. And then before we even think about surgery, usually they'll try Cinecalcet and other methods to try to avoid surgery if we can. The last thing we want to do is operate on those patients unless we absolutely have to. The patients that we tend to operate on are ones that the PTH goes above 1,000, and they've tried all of the medical kind of tricks to try to get it down. A lot of patients don't tolerate the Cinecalcet that well. It has a lot of side effects. And so that's, I would say, the most common thing that I see is like, I tried taking Cinecalcet, it worked, but I couldn't live, it affected my daily life. And, I just can't take it. And so their PTH levels go back up. And usually the ones that I see it's in the 3,000 and 4,000s. And so they're getting a lot of bone resorption and things like that. And speaking of, they get calciphylaxis, so they get these wounds that are calciphylaxis, basically deposits of calcium in the skin. If you biopsy those, they will never heal. So you don't try to debride them like normal wounds because they just don't heal. It's a very, very specific subtype of wound. It's a very bad prognosis, but the only treatment really is parathyroidectomy. That's the only thing, is getting that PTH level down. They also get, severe osteotitis fibrosa, where they get these, bone lesions. And so anytime, again, we see high PTH levels that are resistant to, treatment, or any of these sort of complications from it, is when they send to me. Secondary, I'm really a technician. I do whatever the nephrologist, if they think they're ready for surgery, they send them to me. We operate on them as long as, they're okay from a surgical standpoint and cardiac standpoint, everything. But they manage everything. These patients are not outpatients. They stay in the hospital for at least a week and a half, managing low calcium levels. They get extreme hungry bone syndrome. And so they need every kind of calcium we can throw at them. Basically, we give them calcitriol, we give them calcium throughout the day orally, we give them IV drips of calcium, anything we can do to kind of get those calcium levels up, basically. Options for this. Typically, if I can do a 3.5 gland parathyroidectomy, that's my preference, to try to leave a vascularized parathyroid portion in the neck. The problem with these patients is their parathyroids are huge and they're fibrotic and they're just very nasty. And so it's very hard to leave a viable little kind of normal sized remnant in there when you're dealing with that. And so most of the time, I'd say at least 50% of the time, we have to take all 4 at the time of surgery. There's just 2 abnormal to leave behind. And so in that case, I'll go ahead and take all 4. I take a tiny portion of one and go ahead and transplant it into the arm. You can see that's regrowth right there of a parathyroid autotransplant. And so you can go in and see basically a parathyroid adenoma in there again, but that's kind of what those look like, if not even a little more yellow and parathyroid looking. But that is typically the way we do it. Most dialysis patients, the reason we do the arm transplant is that they're going to continue, if they stay on dialysis unless they get a transplant, they're to continue to stimulate whatever we leave behind. And so it's kind of nice to have it in the arm where I can go back and debulk it if we need to down the road, rather than trying to go back into the neck and risk, all the structures, damage to all the structures that are in there. We talked about that. Tertiary is very similar. It's just mainly, I see this in patients who have had a transplant, but their PTH stays elevated. Most of the time when patients are on dialysis and their PTH is high, if they get a kidney transplant, everything kind of goes back to normal and their PTH will come down and everything kind of works like it's supposed to. But there are a subset of patients that get kind of autonomous function after that. And so if patients have persistently high PTH, or especially if they start to get hypercalcemia and you're trying not to damage the new transplanted kidney, that's when we go in and operate. And most of those patients do need a 3.5 gland parathyroidectomy because all the parathyroids are involved. I try in those patients, since we know they have normal kidney function, we try to lean towards 3.5 gland instead of taking them all and doing the transplant, because there's less subsequent stimulation of the parathyroid tissue over time. And then parathyroid carcinoma is very rare. Like I said, I've seen it in the setting of HPT jaw tumor syndrome. Usually presents with really, really high calcium, really high PTH. And so you kind of have an inkling of it beforehand. A lot of times you don't know till you get in there, though. So it's the ones that I've seen are very hard once you get in there. They're fibrotic. They're stuck to everything around it. It's very difficult to dissect. And so a lot of times, if I suspect that, I'll go ahead and take the tissue around it. If that means taking out that lobe of the thyroid, if I really truly think there's a high risk of cancer in that situation, we would go ahead and do that. Sometimes I'll go talk to the family, of course, but typically lean towards being as aggressive as we can that first surgery, because going back in there is always more difficult. So whatever we can do that first surgery, we do. This is kind of what it looks like a lot of times, just this dense fibrotic tissue. And sometimes you'll see that's more like what an adenoma will look like, maybe a little pinker than that, but this is that dense fibrotic tissue around it. Surgery is really the only treatment for it, or trying to control calcium levels. So a lot of times their morbidity is from how high the calcium gets and the symptoms that come from that. So surgery, obviously, if we can find a target and get it out and get a good resection of it, that's our best bet. But if not, then they're treated medically to try to lower the calcium as much as possible. And that's, I think, about all I have. Sorry, I didn't leave a whole lot of time for questions. Do you have any questions or anything? Yeah. 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 thyroid and everything. Yeah.
Well, but let's say she came back with her current, and at this point, she's 95, but still functional. So, is that something that's being looked at?
I mean, I do think there's talk about that right now. It's mainly for thyroid, but alcohol ablation has been discussed as well. I think that one's a little more reliable for parathyroid. RFA with the parathyroids being pretty small, it's so there is a true risk of surrounding thermal damage. And so I went and did the training for RFA, but I just wasn't super impressed. I'm sorry, super impressed with it. And so I haven't really incorporated it into my practice at this point, but I can see that becoming, as people get more and more savvy with it, potentially becoming an option for treatment too in patients who can't have surgery. But yeah, if you can localize the parathyroid, then alcohol ablation is a nice option too. A lot of the interventional radiologists will do that for thyroid cysts, and I've had a couple that have been willing to do it for parathyroid over the years. So yeah.
You see parathyroids?
I have seen it. It's rare. I had one gentleman I'll never forget because he was in town for some, it was a polka convention or something. I don't know. He's coming from somewhere else and came in with a hypercalcemic crisis and ended up, we did imaging and he had a huge parathyroid cyst, which they thought was the thyroid cyst because it was so big and kind of taking over that entire area. And I was like, well, he needs surgery. He's in from out of town or whatever. And his calcium, I think, was like 17 or something like that. And so we ended up operating and there was no actual adenoma. It was all that cyst. And there was studding on the inside kind of cyst capsule, parathyroid little bud. So, and I've seen it here or there, but yeah.
Definitely one symptomatic.
Yes. Yeah.
So that's something that is a lot of our patients, they're older, they have like.
Yeah.
So we always have that problem that somebody is telling us that, but they don't meet the criteria for surgery.
Mm-hmm.
So what is your experience in terms of do the symptoms improve?
I mean, I would say I try to manage expectations with that a lot. And so I leaned more towards kind of being more negative about it, I guess, and just saying like there's no guarantee. And especially at your age, the symptoms could be from many different things. And so, but honestly, I see them short term. So, there's probably a little bit more long term effect. But I'll see patients that come in 2 weeks after surgery and will tell me at least that they could tell a difference, especially if brain fog, I feel like, is the one that really gets better and the energy gets better quickly, and energy levels and things like that. And their family will say like, yeah, this is real. It's not just, placebo. They're doing more, they're out, they're functional, whereas they weren't before. So I do see a vast majority of people that get some degree of symptom relief. It's not, and then certainly patients with kidney stones, I've seen a lot of improvement, obviously, with that, who their onset of kidney stones coincides with the diagnosis, is the big one. If they've had kidney stones for 50 years or whatever, and they just now got hyperparathyroidism, obviously, we're not going to fix that. But I do see a lot of improvement. Mm-hmm.
That included things like uncontrolled hypertension, a lot of things like that.
Yes.
So one of my VA patients, surgery for that problem. I wasn't that convinced that that's what, that that's a good indication for it.
Yeah. I mean, I think in patients who have a true diagnosis, obviously, if they don't have the diagnosis, then this is not going to make your whatever better. But I think in patients that truly have the diagnosis, I have a very low threshold for offering surgery because I do think there's benefits to it, even if it doesn't fix the thing that they really, really want you to do it for. It is going to protect bones and kidneys over time. And so I do have a lower threshold, I guess, for offering it in those patients, especially if they're healthy and can tolerate the surgery and the risk is very low and everything. Yes. Yes, yeah, I'm very hesitant to operate on those patients, like I said. I know, I get more and more every week. Yes, yes. Oh, no, I didn't see it. Everything got better.
Now they're saying that parathyroid.
Oh, no.
There'll be a huge.
Oh, gosh. It is.
What's the question on?
Oh, there is. I'm sorry. We do see some, so the question is, do you typically see elevated PTH in CKD stage 2? And yes, we'll see mild elevation. Normally those patients have normal calcium, so they don't meet criteria for surgery. And it's usually something that there's a whole table of the PTH to expect at different levels of CKD. And so usually their nephrologist will follow that along. And if that becomes more severe as their kidney disease gets worse, or if they develop hypercalcemia, then those are the patients that we see. And then in asymptomatic patients greater than 50 who prefer to go for surgery, like I said, I do have a low threshold because I do think there's a lot of symptoms that are sort of missed or hard to tease out. And like I said, I think there is a benefit there, of surgery, of curing the parathyroid disease, even in patients who don't necessarily have significant symptoms. But I'm very, very clear about the risks and, kind of outcomes and all of that when talking to the patients for sure. Good questions.
Talking about these devices for following the fluorescence. Now, are there any outcome studies that show that might give a better outcome for the?
It's really hard to study that just because it's so different surgeon to surgeon, and all the surgeons are using them in different ways. So sometimes people are using them in thyroid surgery to see if there's viable parathyroids or if there's a parathyroid on the specimen. I think that might be helpful, but usually I can look at the thyroid and see, you can actually see the autofluorescence just with the naked eye. I mean, it's very interesting that they're kind of, we call them like a glitter pen. The parathyroids look like those old school glitter pens. You can see that. And so I think if you're testing it with a device versus if I'm close enough you have to be right on it to get it to test with the device. And if I'm that close to it, I'm going to see that with the naked eye. So I just don't see a whole lot of.
Because it just seems like you may be adding expensive devices by getting very much out of it.
My thoughts exactly. But there are really people that really, they do a lot of talks for the companies. So I don't know, no stones thrown, but yeah.
Like anything else.
Yeah, exactly. So I usually give it some time to see if, what sticks and what doesn't, and if there's any good research that comes out of it before I incorporate it for sure. So, yeah. Yeah, there's about a 20% rate of persistently elevated PTH after. And so then you get into like, do these patients have normal calcemic hyperparathyroidism, or is this just a response to lowering the calcium and maybe their vitamin D is a little on the low side? So especially in the beginning, I don't really worry about those patients, and we maximize vitamin D, and I put them on calcium and give it time and everything. And a lot of them will kind of normalize over time. Most of them can tell symptom improvement. And so I'm like, well, if your symptoms got better, even if you have this lingering kind of higher PTH, then we don't really do anything surgically about it. It's only the patients that it hasn't been shown to predict recurrence of hypercalcemia. And so usually we just watch it over time. So rarely we'll operate on those, but that's another tricky situation for sure. Not typically. I mean, most of the time we rely, most of the time those patients we just follow over time, but there's, yeah.
But some companies now are making
Yeah.
but the second generation does measure a lot of the inactive metabolites. So
Gotcha. Yeah, maybe picking up something that, yeah.
my understanding was if you see that, you should look at a third generation.
No, I mean, it's a good thought about, most of the time I can find some reason that the PTH is elevated and treat that. And so we don't really dive into, looking further if we can figure out, oh, they have borderline vitamin D or their calcium's really low or something like that. So, but yeah, definitely a good thought if we can't find any other reason before going to surgery, for sure. Oh, I'll do anything to avoid surgery in those patients. They never do well. They don't.
Yeah, so
Yeah.
third generation is much more specific, but it's not as sensitive. So
Gotcha.
it won't pick up as
Yeah,
many,
might be more in the normal range for those patients. Yeah, be interesting to look at that for sure. Good. Well, thank you guys.
Thank you.
Oh.